Before I start the talk, I think I've not talked to Jay about the talk, and it's very good that many of the things I will say will mirror what Jay said, even without us discussing it. So we are all going to send the same message, and that is the same message also what Prof. Barlow said. So a few things may be repeated, but it's worthwhile repeating because that's the message we are giving. A complete history, that's most important, and a few things on our diagnosis. So I'd like to thank my registrar. He put together a lot of recent information from on infection. And why I put this up is the MDT lead. Yeah, as Jay says, we have to discuss everything in a MDT. But what do you think happens in a DAIR? So DAIR is your debridement, antibiotic, and implant retention. What do you think is the difference between DAIR and everything else we talked about the Philadelphia classification, etc.? The importance of this talk is that those of you who are not going to be doing joint arthroplasty are going to be involved with this patient. Is that right? On an on-call. And therefore, unfortunately, why maybe DAIR's results are not good is that decision-making of that, unfortunately, so far has not passed through a MDT because of the time scale. Okay, so that's a point I'm making. So moving on. So I'll divide the plan into why, and that will touch on FRC's auth questions for those of you who are going to do it, and it's come here quite often. Second is difficult decision-making, and that's a fact. You know, we have to make difficult decisions about whether we do something or not. Third is timing as to when to do it, how to do it, and what are the results so far in the literature. So before we start, the classification is more or less what JS says. So when I talk about time frames, I may say 4 weeks, but let's be realistic. At 4.5 to 6 weeks, we can divide into acute or things like that. So one sensible or classification which is treatment-driven, which helps us in treatment as a general orthopedic surgeon, would be as follows. So type 1, or you can call it A or whatever, is a positive sample within 28 days, and like I said, it could be up to 6 weeks, of the index operation. And those of you who are coming to the exam, use these words. Yeah, it joins the club of orthopedic surgeons to speak, saying index operation and a positive sample. What you mean by a positive sample is it's not just me saying, or Tom Syme saying it's an infection. It's a question is, do we have a positive culture? So that's one. And that we agree is acute, and that's no issue about that. That's your first 4 to 6 weeks. The second one is where you have a positive sample beyond your 4 weeks or 6 weeks, and we agree, all of us, we can call it chronic, and there's no confusion about that. So that's beyond that time frame. The third one is what Jay touched upon, is that if you have a positive sample in a knee which is now beyond your 4 to 6 weeks, 5 years down the line, 3 years down the line, but the important word is in a previously well-functioning knee. So if you have a previously well-functioning, fantastic, I've been going to the gym, but bang, something happened. Do you agree? We'll call it a different classification from a chronic, which would be, or it comes under chronic because it's beyond the time frame, but it's hematological spread. So use that. And the fourth is something which none of you, unless you're going to do joint replacement in revisions, will come across, is if I'm doing in a case for aseptic loosening, which I do, and we always send off biopsies or specimens even in aseptic loosening, and unfortunately it comes back as positive, then we call it as a type 4, all right? So that's something which if you want to get out of your mind and forget about, please do, but I just put it in because it is there for us joint replacement surgeons. So moving on, why 4 weeks or 6 weeks is important? And that can be asked in your basic science viva, and therefore introduce the word biofilm, which we've already touched upon, so introduce it. Just to keep it a little more succinct, I've said that there is affinity of staph for stainless steel and cobalt chrome, and Prof. Barlow will expand on it later. I can ask him myself if that's true or not, but it's supposed to be a high affinity for stainless steel and staph most, and then you form this protein biofilm, which Jay has talked about. And The wording which you can use in the exam is, I do know that the bacteria adhere. I do know there's replication of the bacteria. I do know there'll be transcription and translation leading to protein synthesis of my biofilm, which I do know happens from day one, and I know that I want to avoid that, and therefore, if I want to save my joint, in the basic science viva, I will say, because of all these reasons, I want to save my joint, and therefore timing is crucial for going into debride. So this is how I would say it for the basic science viva. Do we have any evidence to support this? And the answer is probably yes. 7 days, the faster you go in, there's a paper supporting 7 days, but there is evidence we can go to 4 to 6 weeks. So the message would be not to do it overnight. We have 7 to 10 days, but do it earlier. So moving on. Now, I like to use the word bold decision-making, because bold decision-making is what Prof. Barlow correctly said. If you're going to debride, he talked about a native joint, but he made a very valid point that if you're going to debride 2 times, 3 times, 4 times, wash out, something is going wrong. And the more you do is not necessarily better for the end outcome. So a good surgical, bold decision and doing things correctly is more important. So let's start. When will you not do a DAIR? So you will not do a DAIR. When do you think? Which is the definite evidence when you'll not do a DAIR? Anyone? Chronic, yeah? So that's the chronic one where you don't know 100%. And it's chronic where that patient is grumbling about his knee right from the start. Never happy. Doc, I hate my knee. It's 2 years down the line. So you agree that's one. The second one, when you will not do a DAIR? Very right. Fantastic. Implant loosening. But that 100% is not going to loosen unless you've done it technically in the first 4 weeks, right? Unless I've really mucked up, I'm not going to have a loose knee. So that's anyway going to be chronic. It's the one which I was talking about as a joint replacement surgeon. I put in my definite implants. I put in all my sleeves, my cones, whatever I want. And then the culture has come back positive. Do you agree? I'm not going to take everything out and do a DAIR. I'll just continue with antibiotics. Yeah, so that's the one. So you will not do a DAIR, yeah, in a so-called chronic infection. This patient, without night, bold decision-making, 1 stage or 2 stage. There is a debate about it later, but that's what this patient needs. I will not do a DAIR in the one I talked about. Definite revision, I've already put it in. Don't worry about it. I'm not going to do a DAIR. So when will you do a DAIR? You will do a DAIR in the so-called acute infection. Happy with that? The first 28 days, 4 to 6 weeks, you will do a DAIR. So what are the difficult decision-makings that? What are the easy decision-makings? So I divide into that. If you have a oozy wound or persistent discharge, there's no doubt. We all agreed, we talked about it. No waiting more than 10 days. Don't say it's going to be better. You need a debridement. So let's accept that. Happy with that? That's your acute one. The decision-making acute? Very easy. If the wound is dry, but you're worried, do you agree you'll aspirate? And if the aspiration comes back positive, we've all talked about it. Yeah, you're going to do an easy decision. You're going to debride and do a DAIR. The difficult decision comes back when you aspirate and it's negative, and then CRP is high, treat a cellulitis. Now, this comes down to clinical decision-making, but I'm just putting it there because this is real life, and we are faced with this. But the end result is we'll do a DAIR, let's all agree, in the acute case in the first 4 to 6 weeks. We will also do DAIR, and this is where it confuses general orthopedic surgeons, that you have a knee which is fantastically well-functioning. He says, I'm delighted with my knee. He's admitted overnight into your district general hospital. It's not a MDT center, it's not a center for revisions. That person has 2-week history of a very painful joint. Do you agree this comes under the hematological, right? Because he has a well-functioning joint. Then do you agree all you general orthopedic surgeons will aspirate, is that right? And that comes back positive, easy decision. That patient needs a DAIR, right? So we are not doing a DAIR for a chronic, we are doing it for a chronic, yes, from time scale, but it's a well-functioning knee. So what did we say? Needs DAIR if we use symptoms less than 4 weeks. Now, when do we have to make decisions which are made by a general orthopedic surgeon? Is we have this group, very, very rarely, but if you're acutely unwell patient, ITU, under the medics, already on antibiotics, we are losing the patient, or we are it's a septic picture. Not always the case, very, very rare. But if that's the case, then forget about whether it's acute, forget about whether it's chronic, forget about whether it's hematological. This patient, if you're very unwell and it's night and you're a general orthopedic surgeon, this is the only time when a non-knee replacement surgeon can make a decision. And what will you do for this patient? Anyone? Yeah, what type of washout? Yeah, we use the word arthroscopic, that's right. So this is the only time when I would say as a knee replacement surgeon, I would allow or accept that someone's done an arthroscopic washout. Now, how many of you all have the skills to do an arthroscopic washout as a general orthopedic surgeon or consultant with all the metal looking at you? So what I tell my colleagues, you don't need a stack. You don't need to see anything if you're saving that person's life. Just put in two large bore inside and outflows and wash the knee out. Save the patient's life. So that's the only time arthroscopy allowed. All other decisions have to be made in your district general hospital by the knee surgeon who has done revisions. Okay, so decisions of DAIR, decisions of 1 stage, decisions of 2 stage, not by anyone else. So, and when do you do it? Not in the middle of the night, not on a trauma list. And this is where, do you all agree? In real life, you have a patient with a wound 2 weeks, 3 weeks down the line, the knee surgeon tells someone else, no, I think it's superficial, I think it's about the fascia, just put it on any list and debride it. That's something which I say should not be done. It's not correct practice, and I'm sure my knee surgeons will agree with that. So moving on, you do it when the revision surgeon is available, and waiting till above is fine, but we're doing it at 7, 10, 12. The faster you do it, the better. How long does it take? As long as it takes. It takes me as long to do it, maybe more than a primary knee, without a doubt. And once again, do you agree, Jay, and my other colleagues? It takes longer than a primary knee, sometimes to do it. New insert, putting in maybe a challenge. What do I use? Again, very important. I use a 5 ml syringe, take out the fluid. I divide my amount of specimen sampling into 3. I use the word fascia, but it's the median retinaculum. It's 4 in the vicinity above that. 4, I use 4, but it could be, yeah, in the retinaculum and deep. And then I take 4 from the back of the knee. So see how many I've taken, but I label them as separate. So it's about 4 to 5, but from different parts of the knee. And how? It's no use just washing. I wash with a purpose. I wash after removal insert. I brush and I use a long nozzle for behind the knee, and I use Colitam, and I use a new 3 liters after the insert. So a few pictures just to finish. So that's me opening. You agree I've opened median, typical medial parapatellar approach or retinaculum approach there. I've already started taking my tissues. My 5 ml syringe, the best place to take it is don't open the whole knee, open here, take it from there. My incision, medial parapatellar incision is done. Now this is important now. Now I straight away start with my debridement. So take 2 tissue holding forceps, hold it on the retinaculum which looks good, and everything else underneath it. See what I'm starting? I'm left-handed, so everything else from here I remove. This is on your medial side. Then I sample what I see in the middle of the knee. Yeah, this is what I see in the middle of the knee, which I sample and take off. Then I'm beginning on the patella eversion, which is crucial. You have to work here. You have to work a lot here in your debridement. I've not even opened the knee. So I work here. I'm everting and circumscribing around there. Tissues again being taken from there. And then the next slide will show that I'm beginning to remove all the tissue from this side of the retinaculum on the lateral side. So again, tissue holding agree. Then all the tissue removed from underneath that. So in other words, I'm getting my gutters free on either side, which is part of debridement and part of exposure. And I'll talk about this in my next talk, which are the specific considerations for exposure or issues with an infected knee. So tissue holding there and removing. Then I can see my implant. And even with the exposure with hyperflexion, you should be, I like to see the back of the knee, even without putting any retractors at the back. And then I remove my insert, and then you see it like this. So again, pointing out that now when I put my retractor at the back here to see my tibia, I'm going to see my whole tibia, including the back of the knee. And that's when my exposure is over and my debridement starts at the back of the knee. So what is the success rate? And this is what my registrar put up for me, is this, and because things are changing. As Jay said, the guidelines came out 1 week or 2 weeks ago? 1 week ago, so things have changed. So the success rate of DAIR, if you truly look at the literature, and this is what you can quote in your exams, is unfortunately a huge variation, 70 to 100%. That's exceedingly great. And that is because so far, decision makings on this has been so varied. Do you agree in real life as well? Oh, let's do a DAIR, let's do this, let's do that. There's no clear-cut guidelines for doing it. And it's heterogeneous because organisms, we touched on. When do we do it? Acute, chronic, so people used to sometimes do it later than it's really necessary. No bold decision-making was made. The host status we touched upon. Again, how we do it, each of these things touched upon have already been mentioned. Yeah? How are we doing it? Are we doing it right or wrong? And the duration of antibiotics. And this is put together from ourselves, from the meta-analysis of all studies to show what your outcome of your DAIR would be. So poor prognosis is definitely all these organisms. And we can ask Prof. Barlow whether he agrees or there's any issue with that. Second is the host factors, where male, unfortunately, greater than 80 years, issues. A high CRP right from the start. So here we're not talking about difficult decision making. We're talking about barn door infections as to who will do well with the DAIR and who will not do well with the DAIR. And good is doing it in this timely manner, yeah, and taking all this off. So the message would be, you agree, a timely DAIR, that is one, without a doubt. Number two, a correct decision making. 3, only by a TKR revision surgeon. Let's all agree that one best DAIR is your best result. There were talks about whether we should do it 1 week and 1 week apart. But there's one factor which has determined in the end. I did a meta-analysis when I was giving a talk on amputation following knee replacement. And there was only one factor which determined that is how many times the patient had previous surgery, either prior to the index operation or during the index operation. So doing unnecessarily repeat surgery, we all feel as surgeons, oh, let's go in and do something. We have to be clear that we do it for the correct reasons and do it well. So let's accept as one timely DAIR. And with now we need to have, because we are getting more and more into MDTs done very easily, we're going to discuss DAIRs more there. And there are only 2 papers I'm ending with. I'm not going to tell you about them, but this was in 2013. So I put 2 papers, historical, 10 years ago, and see, these are the failures. See how high the failure is? And then moving on to a recent paper, the success is still between 60 to 70 to 80. So we are not winning, but at least we are getting there. Thank you.